Good day, I'm Dr. J. Doucet from the University of California, San Diego Division of Trauma, Surgical Critical Care, Burns, and Acute Surgery, and welcome to our video associated with our REBOA Lab. We're going to talk a bit today about the history and indications for the use of the REBOA technique, and we'll show a little bit of video and pictures of how to actually insert a REBOA catheter. The use of an intra-aortic balloon catheter to control blood pressure in patients with significant intra-abdominal hemorrhage is not a new idea. The history of REBOA actually goes back to the Korean War. Dr. Carl Hughes, a well-known vascular and trauma surgeon, thought about the use of an intra-aortic balloon catheter in combat casualties at that time. However, the technology was somewhat limited, and the idea kind of faded away. In the 1970s, the idea of using a Foley catheter to occlude the aorta in aortic surgery returned. However, the technology was not considered to be good enough at that time, and again the idea fell away. In 1989, the idea of using the intra-aortic balloon returned for the management of penetrating abdominal trauma. This series showed that there was technical success in most patients it was attempted in. However, there were some technical limitations, one of which was the use of the 12 French sheath to introduce the balloon. More recently, the use of endovascular surgery has provided new technology and techniques to allow intra-aortic control of bleeding. In the current era, there is now enthusiasm for use of an intra-aortic balloon to obtain control of bleeding. This first originated in Japan and other areas and has now arrived in the United States. The idea is to advance a balloon within the aorta either to what's called zone 3, just above the bifurcation of the aorta, or in zone 1, in the chest, in the descending aorta above the diaphragm, to control intra-abdominal bleeding. Starting about 2 years ago, we've seen an increase in the use of REBOA catheter in trauma centers to control patients both with intra-abdominal bleeding and, in this case, with severe pelvic fractures. The limitation of the 12 French sheath persists. However, on the horizon are new catheters that may have a smaller diameter, which may make the technique more palatable and have fewer complications. In Japan, the use of REBOA is associated with smaller catheter sizes, and there are 7 French sheaths available for those catheters with those balloons in Japan. Hopefully these will soon arrive in the United States as well. Looking at the effectiveness of intra-aortic balloons, one of the issues has been the lack of prospective studies, but there is some retrospective studies showing its effectiveness, particularly in a larger series available in Japan. In this series from Japan, the use of intra-aortic balloon occlusion was associated with a significant increase in blood pressure, and this was similar for both survivors and non-survivors. Heart rate was not much affected. The use of intra-aortic balloon was also associated with a significant decrease in the need for transfusion, particularly in survivors. The amount of time to insert the catheter was similar in both survivors and non-survivors. However, the duration of therapy was significantly shorter in survivors than it was in non-survivors. The use of a 7 French sheath end balloon allows for rapid insertion, and this fits well with hybrid ER and trauma bays and ORs, which are available in some Japanese centers. The use of REBOA in hypotensive patients who are either partly or not responding to fluid resuscitation starts with accessing the common femoral artery, usually for an A-line or for the insertion of the REBOA catheter. A chest X-ray is necessary to ensure the patient has not got an aortic injury, which is an absolute contraindication to insertion of REBOA. Then a fast exam helps determine whether or not the patient has significant intra-abdominal bleeding. This then requires that the REBOA catheter be placed in zone 1 to occlude any bleeding that might be occurring in the abdomen. If the fast is negative, the pelvic X-ray will also disclose whether or not the patient has significant pelvic fractures. If so, the REBOA catheter would be inserted in zone 3 to stop pelvic bleeding. Another study looking retrospectively at the use of REBOA in the Japanese population looked at propensity score adjusted untreated patients as the control group. A Kaplan-Meier score of 30-day survival from patients who received REBOA or propensity score matched control patients showed that the survival of REBOA patients was about 30% overall, with most of the mortality occurring within the first few days. This indicates that REBOA is being used in a group of patients who have significant mortality. Whether or not these groups are actually completely comparable is not known because of the selection bias here, but REBOA is being used in a group of patients with high mortality. How to train for the insertion of the REBOA catheter. Cadavers offer one option, and in fact, cadavers can also be pressurized with their central circulation that can provide a more realistic situation for insertion of the REBOA catheter. Alternately, some centers have access to vascular simulators, and these can provide a realistic insertion experience as well as a type of simulated imaging for insertion of the wire and catheter. There is a discrete series of steps for insertion of the REBOA catheter. This is taken from a paper from Dr. Rasmussen's group, which show the techniques inserting this catheter. The equipment available varies from center to center. At UCSD, we have a 14 French balloon, which requires a 14th French sheath for insertion. The desired zones for deployment are Zone 1 and Zone 3. Zone 1 for intra-abdominal bleeding, Zone 3 for pelvic bleeding. We should avoid deployment in Zone 2 because this is where the orifices for the celiac, SMA, and renal arteries are, and we do not wish to occlude these. Zone 1 is above the diaphragm in the descending aorta. Zone 3 is below the renals and above the bifurcation. These are the 5 steps for insertion of the REBOA catheter. 1. Obtain arterial access. 2. Position the balloon. 3. Inflate the balloon. 4. Deflate the balloon. And 5. Remove the sheath. It's necessary to use a large amount of draping because of the large length of these catheters. The REBOA kit that has been made available has an abundant number of drapes, and these should be used to ensure that the catheters and wires do not become contaminated. First, we must obtain arterial access. Options for this include ultrasound guidance versus open techniques or using an existing arterial line. The technique for patients who have not been punctured already include the use of a micropuncture kit, ideally associated with use of ultrasound. And this has a short sheath included as well as a small wire. Insertion of the small sheath that comes with the micropuncture kit allows us to introduce a 0.035 wire into the common femoral artery. We must be careful not to cause venous puncture, enter the artery too high or too low, which can cause problems with insertion, and we must not assume that the groin crease is necessarily the inguinal ligament. We like to insert the catheter just at the inguinal ligament if possible. Our puncture should be made about 1 centimeter below the inguinal ligament if possible. The micropuncture kit, as shown here, uses a small needle which can be inserted under ultrasound. It uses a small wire which allows us to place a catheter which can be used to introduce the 0.035 inch wire. This is an ultrasound guided procedure, and you notice that the ultrasound is being inserted with the ultrasound probe located just at the inguinal ligament. The needle is advanced at a 45-degree angle, and aspiration can confirm intra-arterial location of the needle. Open technique is also possible, particularly if the pulse is difficult to feel or if there's difficulty in locating the artery. This then allows direct insertion of the needle, then wire and sheath. Many U.S. centers are using an Amplant's stiff wire for initial insertion. However, the Lunderquist wire is available at UCSD, and this has some advantages. This wire has a soft loop at the end and provides some tactile feedback when the end of the wire encounters the aortic valve. This provides additional reassurance of where the wire is located and avoids intra-carotid or intracardiac positioning of the balloon. The wire that is used is quite long, 200 centimeters, and therefore it's important to manage your wire. You should use the enclosed wire holder and ensure that there's adequate draping so that the wire can be kept in a good position and not become contaminated or accidentally pulled out. After insertion of the Lunderquist wire, it's now necessary to insert a 12 French sheath with dilator into the femoral artery. The length of sheath can be either short or long, depending on whether you wish to place the balloon in the zone 1 or zone 3 locations. You can see that the wire here being in position allows positioning of the 12 French sheath with its dilator into the artery. Once the sheath is in place, it's now time to position the balloon. There are some options to determine where the balloon is actually located. Usually, we use fluoroscopy if available, and this can confirm that the balloon is placed in either zone 1 or zone 3. Alternately, you can use X-ray. As we resuscitate our patients on X-ray tables, it is possible to get a rapid X-ray. Ultrasound may also be possible in some locations, particularly at zone 3. Our technique for insertion involves using our 12 French sheath we now have in the common femoral artery. We use this wire and sheath to introduce the coda balloon, which we confirms location in either zone 1 and zone 3 by the use of fluoroscopy or X-ray. We have to ensure that the wire is not moving inadvertently and becoming too proximal or becoming too distal, which allows injury to the aortic root or the carotid arteries or other structures. Measures to ensure safety involve the use of either fluoroscopy or marking the length of wire outside of the patient before insertion. We also ensure that the wire is pinned or secured in location to prevent advancing or retracting the wire inadvertently as we position the devices. It's also important to ensure that we have a generous skin opening around the wire entry site using a scalpel. The balloon we use at UCSD is the coda balloon. The coda balloon fits through our sheath. It's important not to do a trial inflation of the balloon prior to insertion. Once the balloon has been inflated, it will not go back to its original size and may not fit through the sheath. Therefore, do not inflate the balloon until it's actually inside the aorta and ready for use. We inflate the balloon with a mixture of contrast mixed with saline to ensure we can see it on fluoroscopy or X-ray. The balloon is inflated until it adopts the aortic wall profile, and then we turn off the stopcock to make sure it's inflated. With inflation, we should see a dramatic increase in central aortic pressure. It's important not to overinflate the balloon and cause any damage to the aortic wall, and we have to ensure that the balloon does not migrate distally or that it does not allow the sheath and wire to be pulled out against the inflated balloon. Hazards to look out for is to make sure that we do not overinflate the balloon and cause damage to the aortic wall, or that the balloon sheath and wire do not become displaced distally due to pulsation. With proper positioning, we should see an increase in blood pressure. We should also ensure that we have imaging showing the balloon in the proper location. Once the balloon is in the proper location and we've seen the desired increase in blood pressure, we may have to package our patient for transport either to the operating room or to the angio suite. It's important to package the patient properly, and therefore we should take care to make sure that the wire, coda balloon, and sheath are properly secured and kept clean. The sheath may be kept in place while the balloon is in place or after balloon removal. Maintaining the sheath may require a slow infusion of heparinized saline to ensure that it does not clot off. Endovascular procedures can generate a large amount of trash, including excess catheters and wires. It's important to control the location of these items during the procedure and afterwards to ensure we do not cause contamination to the patient or injury to providers. Balloon deflation occurs once the patient's attained hemodynamic stability. We do this by turning the stopcock and deflating the balloon through the balloon deflation port. This should be done slowly and after communication with anesthesia and members of the resuscitation team so they anticipate the patient becoming hypotension. Hazards of doing this include profound hypotension and possible loss of the desired balloon and wire position, which may require use of fluoroscopy and readvancement if we want to reinflate the balloon. Sheath removal involves closing the arteriotomy site. This probably will require open exposure or cut down on the sheath entry site and closure with suture. Currently, we don't have closure devices for such a large device. However, it is possible that with smaller sheaths in the future, with smaller devices, a closure device could be used. The technique involves proximal and distal control above and below the sheath entry site and closure with something like a 5 or 6/0 monofilament suture after removal of the sheath. It's possible to have loss of arterial control and blood loss with removing of the sheath. or to have an ineffective arterial closure, which could lead to bleeding or pseudoaneurysm. A vascular consultation before removal is indicated. If you have questions about our REBOA technique, please contact myself, Dr. Doucet, at the Division of Trauma, or one of our attendings.